going. Okay, welcome. Thank you so much for being here. My name's Kate Shea. My pronouns are she, her, and I'm the Senior Manager of Clinical Programs with NCSD. I'm really excited to be hosting this webinar today in collaboration with Orasure Technologies, and really excited to have our three wonderful speakers on. So before we get started, just a couple of reminders. Please drop any questions you might have for our speakers, even as they go through their presentation in the Q&A box, as opposed to the chat. It's a little bit easier for us to track that way. And we will have a Q&A session at the end, so we'll be able to answer those questions. And you'll also have an option to use the raise your hand feature during the Q&A session, and you can come off mute and ask questions live as well. This recording will be available at the end. I will drop a link to our clinic webinar archive in the chat so that you can access that. It'll be up a couple days afterwards, but you will be able to access this recording. Excuse me. Finally, we will have a webinar evaluation at the end. It's just a few questions. We use this to improve our webinar production, so please answer those questions if you're able. And we have, as I said, three wonderful speakers today. So before we get started, I'm going to go ahead and introduce them, and then I will give them the floor. So our first speaker will be Megan, tuning in from Ohio. Megan Stafford is the STI and Viral Hepatitis Prevention Program Sciences Manager at the Ohio Department of Health. She received her BA in psychology from Marshall University and her MA in applied social psychology from Claremont Graduate University. The focus of Megan's career in both public and nonprofit organizations has been supporting the efficacy of STI, viral hepatitis, and HIV prevention and sexual health programming through rigorous evaluation and quality improvement initiatives. Really excited to have Megan on. And then the second part of our webinar will be Danae and Rachel, tuning in from Idaho. So Danae is a public health professional is a public health professional, leader, innovator, and collaborator with a passion for fostering collaborative partnerships, championing innovative ideas, and advocating for vulnerable populations. Danae holds a Master of Health Sciences with an emphasis in health policy. She is the Health Program Specialist for the Idaho Department of Health and Welfare, Division of Public Health Hepatitis Prevention Program. And Rachel is a registered nurse manager with Eastern Idaho Public Health. She earned her bachelor's degree from Western Governors University and has been a nurse for 18 years with 14 years of public health experience, specializing in the STD, HIV, hepatitis, and family planning programs. As I said, we're very lucky to have all of them on and speak to their experience. So I am going to go ahead and give Megan the floor.
Thanks, Kate. Hi, everybody. Again, Megan Stafford. I use she, her pronouns, and I'm the Program Sciences Manager at the Ohio Department of Health for STI and viral hepatitis prevention. So today, I will be talking to you all about how in Ohio we have supported syphilis testing in local jails. So my subtitle here is Lessons Learned in a Decentralized State. So for a little Ohio context to start with, Ohio is a decentralized home rule state. So what that looks like for us is really from the state level, doing a lot more of the supporting, either financially or with protocol development or morale boosting when necessary, rather than really providing those services on the ground. We have 108 local jails and 112 local health departments. So that's a lot of different entities that could be potentially involved in this work. As far as testing for syphilis specifically in jails in Ohio, we've really seen three different setups that we have kind of supported people through or worked in conjunction with. So the first is probably the most common for us is local public health entering the jail and performing the testing themselves. Generally, that's a county health department going into a county jail. That's where most of the level sits, but sometimes we do have city jails, and sometimes we have a couple of health departments who serve multiple jails, like a single health department will do multiple jails. So we see a lot of different setups that are some iteration of that. The second kind of setup that we have seen is contracted medical care within the jail itself. So you might be familiar with NAF Care. We've got another one in Ohio called Vital Core. It's where like a private entity is contracted to provide healthcare within the jail, and then they end up doing the syphilis testing. And then some of our local public health departments are also FQHCs within Ohio. So they sometimes have a more formal relationship with the local jail. And in those situations, we probably have the least interaction with them because the FQHCs have other funding sources and support systems, and they provide services outside of just the STI services. So they tend to operate a little more independently. And then just as a note, the Ohio Department of Rehabilitation and Corrections provides universal opt-out testing for syphilis, along with a whole panel of other things at prison intake. So really today, I'm only talking about jails, and what happens in prisons is completely separate. So to give you a little background on where syphilis rates are in Ohio, I'm sure a lot of people are familiar with rising syphilis rates in the country in general. So we have kind of the dashed lines here, our US lines since 2018. And then my solid lines are the matching demographic for Ohio specifically. And you'll see I have 2018 through 22 for both groups, but then I went ahead and added our 2023 data for Ohio since we just finalized that and got our reporting done recently. But of course, CDC hasn't released national numbers yet, so none for that. I'll be interested to see if they kind of track the decrease we've seen in Ohio. But the big thing to note on this slide is in 2018, the Ohio numbers for each of these demographic groups were decently below those national numbers. And since then, we started to see our Ohio numbers creeping up to catch up with national numbers. And then in 2022, we surpassed national numbers for men and women. So our total obviously reflects both of those. So very interested to see what happens with 23 numbers and whether or not that surpassing will kind of be sustained. But the big takeaway here is we have a syphilis problem in Ohio. And along with that problem, we've seen, the demographics of who is getting syphilis has changed a lot. I think this is true, nationally. You saw that rates among women are rising, and for us, rising more steadily at a higher rate. The increase is a higher rate than the national numbers as well. And since about 2022, we've seen an increase in the percentage of syphilis cases that are reporting incarceration within the previous 12 months, which is what we're looking at here. So I have 2019 through 2023. And you'll notice that this bottom red line for MSM, that rate has stayed pretty steady and relatively low for the percentage of the MSM who are reporting incarceration within the previous 12 months. So really, we're seeing that increase of reporting a history of incarceration in men who have sex with women only and in women. So that's really, those groups are where we're seeing the demographic shift in Ohio. So that demographic shift is part of what brought us to jail testing. So we are seeing a lot more drug involvement. We started seeing I didn't have a slide for it or data for it, but we were seeing a lot more CS cases as we were seeing these rates rise in women specifically. And we do a much deeper dive into CS cases and discussing at the state level all of those CS cases than we tended to do for other syphilis cases. And we were noticing a lot of drug involvement, a lot of history of incarceration, transactional sex, all of those really high-risk activities. So that was part of what started to change our focus to jail testing. And I'm sure many of you know, those tend to be really hard groups to reach. So this was one way we tried to reach them. Some other initial considerations when kind of setting up or conceptualizing these programs, and this part is really tricky for us as this, in our decentralized state, but who's paying for testing and who's paying for treatment. So you can't just set up a testing program if you don't have a pretty solid plan for treatment, especially because, somebody has to be responsible for that. If you as public health, which is generally what we see public health going into a jail, are trying to set up testing, the jail themselves will be responsible for treatment. And that can be a big barrier. They're generally, at least in Ohio, I assume this is true in much of the country, um, jails are under-resourced and understaffed. And they simply can't afford to do significant treatment. But if they know someone in their care is, for us specifically talking about syphilis, has syphilis, then they know they're responsible for that. So that it can really open a can of worms if you don't have a plan for treatment. One way we kind of deal with that in Ohio is partnering with everyone we can that we know is doing this work within the public health sphere, to offer treatment at 340B pricing through our public health system. Or by that I mean kind of our network, not so much a formal infrastructure, but through all of the health departments we have relationships with. Another consideration is that kind of that's the setup question gets at, but who's performing the testing? Who is actually doing this work? Is it public health that's going in? Is it the jail staff? Is it some other third-party agency, the FQHC? So for us, right, it's not, since we are none of those, that we're not local public health, we're not the jail staff. It's who do we need to find at, if we know, especially if we know we have an outbreak in an area or a specific geographic location that we want to target, who can we find that fits any of these that might be interested in this? Who can we get on our side? Who can we convince that syphilis is a problem? And then how do we get them into contact with the people they need to be in contact with, which generally is at least public health and jail staff, to make this testing happen. And then, I'm specifically talking about syphilis testing today, but there's also the question of what all is being tested for. We do see a lot of different combinations of this in Ohio. Is it just things you can offer rapid finger sticks for? Are you doing, also urine screens or vaginal swabs? The space and like physical space needed for those differs, right? Depending on what you're testing for and what kinds of samples you're collecting. So that's kind of a consideration. Another reason maybe, and I'll say this several times, but there's not, at least in Ohio, really a one size fits all approach because the physical space will differ a lot based on where you're going. The amount of time you have will differ a lot. So there's just a lot to think through. I know and no answers I can give on that, right? But knowing kind of the local situation specifically, then you can kind of go through each of these things. Like, can we do point of care testing for chlamydia and gonorrhea, the Bisbees or Binks, if, there are different possibilities for those, or is it just syphilis, HIV, HCV, things I can do a finger stick for? So we have different things happening at different places in Ohio, but one thing that we really like about point of care testing specifically for jails is easy setup for temporary use in non-clinical spaces. So one, I'll talk specifically about kind of a pilot project that really kicked this off for us in Ohio, but they set up in the jail library. So it can be, a little bit easier to do point of care testing there than, having to draw blood maybe for every person that walks through the door. A really big one for us is getting quick results. Jails have a lot of turnover. It's not always anticipated. We don't always know, if they're going to be there tomorrow, even. We try to ask for anticipated release dates or if they know of a transfer date, but they don't always know. And even if they do share a date, it's not always accurate. If they share what they think will happen, that's not always accurate. If they think they'll be released or they often don't know if they're going to be transferred. It's just is such a complex system to go into as an outsider kind of. So quick results for point of care testing can really help not lose people to follow up, especially before you can get them treated. And then that's the second big thing for us, right, is really getting that quick identification. And then it allows for aggressive treatment. And by that, I just mean essentially rapid, quick treatment to interrupt transmission, which is really what we're getting at here, right? Is we don't want people spreading more syphilis if we can help it. So I have a lot of questions here, which are kind of when someone comes to me and says they want to do jail testing, this is what I walk them through. So because we're kind of supporting from a higher level and I are at the state here, I say, okay, how often are you going to go in? Or what is triggering testing? So if it's a very small jail in a small low morbidity county, maybe the jail can call public health and say, hey, I have someone new who's interested in testing. Would you be able to come tomorrow to test them? If it's a little bit of a larger county, higher volume jail, maybe public health just goes in every other Monday, for example, or every Monday. Is it, offered to the full census? Are you offering a different dormitory every week? That'll depend a lot just on size, on what the jail has the capacity for specifically, and on how much time public health can devote to going into this separate space, if that's what's happening. If it's, that situation of the kind of third-party medical care provider that's contracted within the jail, maybe they can't test everybody at intake, or maybe they can test everybody that's reports symptoms or reports risk factors, something like that. It really depends on the setup there. One thing that we always really try to strongly suggest, we really appreciate for people to have is the capacity for venipuncture for confirmatory testing on site. So that rapid is great to get people in and out quickly and to know kind of a baseline. What are we working with here? But the ideal for us is that any rapid positive is followed immediately by a collection of a serum sample for confirmatory testing to get that RPR. And then also that allows, if you have previous positives, which of course you can't use the rapid for, you can still offer them if they're interested, non-treponemal testing to make sure they're not a new case of syphilis. And then that also allows for presumptive treatment at that point, like treatment based on symptoms or based on that rapid positive, kind of depending on what your situation is. And not losing that surveillance information of what was their RPR, on the day of the clinical encounter. And then the final thing I have here is, how can you as public health, or how will the jail facilitate DIS follow-up? So this testing situation is not always, in being done by a local health department that has DIS. That local health department might not be familiar with what DIS do. The jail itself might not be familiar with what DIS do, but we always ask people that are entering this space, we educate them on what DIS do if we need to first, and then ask them like what they can do to facilitate that follow-up, because we know that these populations are hard enough to follow up on anyway. We do sometimes have jails or prisons that are difficult for our DIS to get into. So once we're building these relationships, it really gives us an opportunity to, even outside of these testing programs, educate on that and ask how we can kind of grease those wheels to get DIS the access that they might need. So I've alluded to some of these before, but challenges we've seen, barriers to kind of pre-plan for if you can. The biggest one really is jail staffing capacity. So even if it's public health going in and doing the testing, there are requirements of the jail staff. They have to be available to escort public health in and out, to escort the inmates potentially, to, really just ensure safety for everybody. And when I talk a little bit more about our pilot project, most of the weird problems that came up, issues that they had, it was around jail staffing. They turned us away at the door today because they just don't have the staffing capacity to support it. So even when the jail is on board, it still is never black and white. Another challenge that we have in some locations is the setting up of standing orders for testing and treatment. We have a couple jurisdictions with health commissioners or medical directors that are just not comfortable having standing orders for, this is more, especially when it's our DIS going in. And we have other locations that don't have that concern, right? So it's really what kind of support can you get from your leadership? What are they comfortable with? And that's will vary a ton, at least for us in Ohio, it does. And then I've already talked about this a little bit but loss to follow up due to transfers and releases. What can you do? What can you have in place ahead of time that will limit those as much as possible? So I'll talk quickly. I've alluded to this a couple of times, but to the pilot project that really kicked this off for us. We have a grant opportunity that we provide in Ohio that was originally funded with the workforce expansion dollars. But it is a really cool project. It's like my favorite little thing that we do because we can really fund innovative approaches to STI prevention. That's what it's called. But any innovative project that people think will, you're good. It's back. Any innovative project that people think will reduce STIs in their region, if they can kind of give me good data on it and tell me how they're going to evaluate it in a pretty rigorous, we do have pretty rigorous evaluation requirements, but we get all kinds of cool projects. So we had a more rural county in our state come to us with this idea to do jail testing. It was at the same time that we were seeing this demographic change in syphilis. And so we're like, yes, this is great. We've done other projects trying to integrate with, harm reduction, and we have had issues with uptake of testing. So we're like, yeah, we think this could really work. So that local health department had a nurse practitioner and a registered nurse who went together to the jail weekly at first and eventually transitioned to biweekly. Initially, the local health department staff would go around to each of the dorms and ask each person individually if they wanted to be tested. Word of mouth kind of built from there. People who had been incarcerated longer kind of got to know the deal. And so eventually just the jail medical staff would keep a running list of individuals who had requested their services since the last time they were there at the clinic. And that list of people who were specifically requesting was enough to get them through their entire allotted time for testing. So the LHD staff would request that the jail staff escort individuals on the list. They would kind of just go down through their list and say, okay, we need, John, and then they would go get John and escort John to a private room. I mentioned it was their jail library that had been set up with those clinical supplies. So the big takeaway from this that kind of, I think, surprised the local health department that we were supporting and surprised us was that testing uptake was just, it was great. It would surpass everyone's expectations. They had their time slot filled pretty much every time. People were just really interested in getting tested in this setting, which was very exciting for us. So first year data, they've done this every year since, but the first year was, I think, 2020 into 2021. So they had 97 rapid syphilis tests with 4 positives. 78% of those people who had testing done had not been tested in the last 12 months. 71% reported at least 2 risk factors, and 25% self-reported a history of hepatitis C, which I know Danae and Rachel will be talking about a little more. So we love to see kind of combining those testing options when applicable. And then lessons learned from this testing experience. One actually was the difficulty of maintaining confidentiality in the workflow. So what they found was they would bring people in for getting testing, and then they would have them escorted back to their location. But when someone tested positive, then they would go back to give results. It was kind of obvious, right, that flow was different than it was for everyone else, because everyone else could see, oh, they're coming back for John, whatever. So they had to kind of throughout the course of this pilot change those workflows and make sure that they kept the inmate with them until results were ready. But that limits the number of people they can see, right, per interaction. Another big takeaway, and this was in, again, 2020 into 2021. So this might still be true today, but it might have changed a little bit because we've done a lot of messaging, but patients really underestimated their risk for syphilis, and they had a pretty significant lack of knowledge about syphilis. So they just didn't think they were going to get it. It wasn't on their radar at all. So coming in and saying, "Hey, we're going to test you for syphilis," it's like, why? Why would I want this? Why do I need this? So they had to do a fair bit of educating. And then another thing they found was that it was a little tricky to balance simplicity of data collection with really getting all of the data they wanted. So they ended up adding questions to their little intake questionnaire as they went. And especially as they noticed some patterns, what people were talking about, this lack of knowledge. They didn't initially have a lot of questions around that, or I think is what it was. So added more questions kind of as they went, or identified some other things that they started asking in the second year pilot of the project. And then, as I mentioned before, barriers, especially with staffing shortages, unforeseen lockdowns. So if something happens at the jail, they end up having to go into lockdown on a day you're supposed to be there, then you just kind of miss that day. Or you sit in the parking lot hoping that lockdown ends and you get to go in later. Um, you the local health department staff needed to be escorted in and out. So there had to be a person available to do that. So maybe they were a couple times sitting in the library waiting for someone to come and escort them out for a little longer than they might have liked. Um, there was a lot of unpredictability, even, once workflows had been established. And so concluding thoughts from us, really, so as a decentralized state, again, for us at our level, really the work for us is figuring out who at the local level can do this work, who can we get excited about it, who can we get dedicated to it. So that's representative of the local health departments. For our STI and HIV work, we work on a regional system. So we have 11 funded regions that do the work, but we have 88 counties, right? So we didn't historically have direct relationships with all of those 88 counties. So it's starting to build those relationships to get those other counties into the STI sphere as well. Um, we also worked with our Association of Community Health Centers talking about this work. So that's all of our FQHCs. And then Ohio has a jail advisory board. I'm not sure if every state has one of those, but that was a way for us to get in front of at least jail kind of higher ups. That's not necessarily their medical staff, but it gave us an opportunity to start the conversation about how jail testing could be happening in jails. The second point is like kind of one of my biggest takeaways from all of this work and any non-traditional settings we've tried to do, jail specifically, but literally every other one, especially like harm reduction side. A lot of stakeholders are willing to let testing happen, but don't necessarily have the capacity to make testing happen. So when health departments are reaching out to jails for the first time or to other locations, it's like, yeah, sure. If you are going to make everything happen, we will open the door to you. We've also seen that at SSPs, at drug treatment facilities. It's really local public health has to come with the excitement and the resources and the money and the testing capability and the treatment capabilities, and then doors will open to them. And again, as I've mentioned, there is no one size fits all approach to this, especially in a decentralized and home rule state. What the ground looks like in every county is different. So we do our best to support people wherever they are, to support them with whether it's 340B funding when we can, if we have that relationship with them, or just talking through their protocols, figuring out how we can share our best practices from other testing, linking people with other counties that we know are kind of similar size that are facing some of the same challenges or have a similar setup. We're really just kind of the chess masters. That's a terrible thing to say, but in a positive way, like just, making the resources happen when we can and linking people when we can't, rather than on the ground doing the work ourselves. And I think I have a question slide, but I think we're going to wait for questions until the end. So I know Kate said put them in the Q&A, but I will be happy to take questions at the end. Thank you.
Thank you so much, Megan. And I know someone has already dropped into the Q&A if they can get your contact info to connect with you about the work they do. So here it is. Please take down Megan's info if you want to reach out to her. Yes, we will have time for Q&A at the end. I see already several questions have come through. So just a reminder, you can put your questions into this Q&A box as we go, and we will address them all at the end. Before we move on to Danae and Rachel's presentation, we're just going to stop to do a brief poll. It's just 2 questions. So I'm going to pull that up now, and I will have you all just take a couple minutes to complete that. All right, looks like mostly everyone has completed this, so thank you so much for participating in the poll. And we are going to move on to Danae, and Rachel's presentation. So let me just pull that up. All right, Danae and Rachel, go ahead.
Perfect, thank you. Hello, everyone. My name is Danae Schomborn. As Kate said, I use she, her pronouns. I'm so thankful to be here. Rachel and I are excited, and we appreciate the opportunity to talk about our county jail testing, the work that we're doing in our county jails. Next slide, please. All right, so I want to provide a little context about Idaho and the public health landscape. So Idaho has 44 counties. 35 of our counties are rural, and 18 are considered frontier. We have 7 local independent public health districts throughout the state. Each of those public health districts are spearheaded by a district director who is responsible for their board of health. And then each of those 7 districts also have a little satellite districts throughout the counties that they serve. And public health in Idaho is a collaborative partnership between Idaho Department of Health and Welfare, so that's our state health department, our local public health districts, and then we also work with our county jails. So next slide, please. All right, so Idaho correctional landscape. We have 37 county jails throughout the state. We have 9 state prisons and 5 reentry centers. And I'm sure that many of the jurisdictions that you guys reside in are pretty similar with the state health prison system is a little bit different than our county jails. So with Idaho Department of Correction, that is our state prison system. 37% of the individuals in the state prison system are sentenced on drug charges. Everyone that comes through the door, about 15.7% have a current HCV infection. They do opt-out testing. That happened in August of 2021 when there was a $13.3 million settlement over 4 years for them to treat hepatitis C. In 2023, they treated 529 people for HCV treatment. They treat about 8 people a week, and they do, when they initiated the hepatitis C treatment at the state correction level, they did base that off their FIB score. So those with a higher FIB score receive treatment first. Now, our county jails in Idaho are very different. There is no standardized HCV testing. They operate on a lean budget. It's county funded. It's not state level funded. And then HCV testing is upon request, so they have to opt in. And we'll talk a little bit more about that in the later slides. Next slide, please. So our network of collaborative partnerships, we have 22 collaborative partnerships across the state. Those include our health systems, our FQHCs, our community-based organizations, our recovery centers, our public health partners, and our corrections. So we partner with these organizations across the state. We have implemented either MOUs or subgrants. And my organization, provides those point of care test kits. So we really want to increase HIV, HCV, and STI testing across the state. Now, with those collaborative partnerships, we formed a stakeholder group for the elimination planning effort. So I'm the hepatitis prevention coordinator, and our goal is to work on the hepatitis elimination plan. And through that stakeholder group is really where we have been able to do a lot of work in our county jail. And so they are our subject matter experts. They are the boots on the ground individuals. They identify the gaps, the barriers, they see trends before we see it in the data, and they really let us know what's going on in the state. And through that partnership, we have learned that really we needed to figure out how to get away, not only do the point of care testing, but how can we get people and get folks confirmatory testing. And so through grant funding, we initiated our confirmatory testing with our state laboratory, Idaho Bureau of Laboratories. And then with that group, our subject matter experts had helped us understand that we really have a missed opportunity if we're not screening in the county jail setting. So in Idaho, we have no state funding for the work that we do. Everything we do is grant funded. And then we also rope in our rebate funding to try to do some creative work in the state. And with our limited resource and our limited time and our limited money, we wanted to figure out where are the areas that we can make the greatest impact with the limited resources that we have. And we determined that our county jail is an area that we need to focus on. And so this group really helped us form that work. And we're trying to, because it's so patchwork across the state, like I said, we have 37 county jails across the state, and not every county jail wants to do HCV screening. They do HIV and STI, some will do HCV screening. And so really we're trying to form, get in with the county jails that allow us to come in and allow us to screen through our partnerships with our public health. And then not only that, but really trying to create a template. And once we have a seamless template, we want to be able to take that template and build it across the state. So we're really excited about the work that we're doing. And our stakeholder group has really been vital in helping us figure out where we can up our screening and where we can utilize our resources and our time. Next slide, please. So this slide, I wanted to talk about chronic hepatitis C. And so these are the numbers. So you can see on the screen, we have our data in each of our public health districts, what our chronic hep C looks like across the state. And so we had 891 individuals diagnosed with chronic hep C. And really with our stakeholders, our decision makers, and my leadership, really trying to show the importance of screening and testing compared to doing nothing, right? So what is the impact? We know chronic hep C can lead to end-stage liver disease. The estimated health impact on that healthcare cost is over $46,000. And now if 891 individuals never received treatment, they all ended up with end-stage liver disease, you can see the estimated cost on Idaho and Idaho families would be $41 million. But if we look at that and we take that test and treat model and we take our point of care test kits, we get ours from McKesson, so it's a little over $19. We take our confirmatory testing through IBL, which is about $70. And then we utilize our 340B pricing. When you really look at that and then the additional lab costs at our FQHC pricing, you really see that comparison. So to screen and to treat versus do nothing, it's a little over $18,000 to screen, treat, and then if we do nothing, it's that a little over $46,000. And then we know that if somebody has end-stage liver disease, the estimated impact for a liver transplant is over $163,000. So this is really good to show our decision makers, our policymakers, the vital importance of testing and treating, the importance of point of care testing versus doing nothing. Next slide, please. So talking about the impact of rapid point of care testing, and I think the numbers from the previous slide, the numbers show us how important point of care testing is, but really also the stories. So I said we partner with 22 stakeholders across the state. And when we look at that and we look at the stories that people, when they receive that point of care testing and then they receive treatment and the impact on their life. So with one of our stakeholders, they provided point of care testing to a high-risk individual with high risk. And they had a confirmed HCV test through our point of care test kits. We were able to get them in to an FQHC, a local FQHC. They received treatment. and really just the impact of their life. They were very sick. They were unable to work. Their provider wouldn't do the other treatments that they needed to get done until their Hep C was cured. They got that point of care test kit in January of 2023. They started on treatment in April, and by July, they were cured of their HCV, July of 2024. And, now they're working and they're so happy. And those stories are what's the impact of point of care testing and the work that we're doing in Idaho. So from here, I'm going to turn it over to Rachel to talk about the next two bullet points. Rachel.
Thank you so much, Danae. It's a pleasure being here talking with you all today. So from my perspective, I am with the public health department that is in the county jail systems. Can we actually go back to the previous slide, please? Thank you. So just to discuss some impacts of rapid point of care testing, point of care testing within the county jails has vastly improved the testing experience. Some examples of that is the testing experience, being able to utilize a finger stick instead of a venipuncture alleviates undue stressors for those that are being tested, such as persons who are concerned about being triggered from previous injection drug use and venipunctures. Sometimes that's just not a good option for them. Point of care testing also improves efficiencies for staff members, such as being unable to find a good vein, requiring multiple sticks, things like that. So it improves efficiencies as well. With point of care testing, we are able to perform confirmatory sample collection in real time, which provides a peace of mind and reassurance. One, for those that have a non-reactive result, we're able to give them that peace of mind right then and there, but also being able to draw for confirmatory testing on site after a reactive test result is found. This also allows us to educate the individual on what the next steps look like for confirmatory testing as we're face-to-face with them. Next slide, please. So this is just some rough data on the number of hepatitis C point of care tests conducted between September of last year to August of this year. With the CDC grant funding, Public Health District 7, which is where I am from, provides testing outreach to 3 county jails: Bonneville County, Jefferson County, and Madison County. We're able to do testing in all of those areas as well. And we also try to do probation and parole programs and court-ordered drug treatment programs. From this data, approximately 39% of individuals tested in injected drugs within the past 12 months. Some of the numbers do seem a little bit low. We do have a lower population in Idaho. However, we do see individuals choose not to get tested because they have a known history. So if they're not going to be treated or they're not going to have any new information given to them, oftentimes they will opt to not be tested. With the pilot project we have implemented, which we'll be discussing in later slides, I do hope to see that those numbers of people being tested and confirmatory tests being done increase. We are also able to provide testing for chlamydia, gonorrhea, and trichomonas, site-specific, so rectal, pharyngeal, and genitourinary samples. And then we're also able to do other point-of-care testing for HIV and syphilis. Next slide, please. So the process that an individual goes through to get tested at the county jail, as Danae mentioned, it is an opt-in testing. Basically for funding, staffing time, a lot of things go into that decision for it to be opt-in versus opt-out. So an individual who's incarcerated in the county jail will submit a medical request form to their medical staff. Those requests are then gathered by jail medical, put into a scheduled date and time where us as the health department go in to perform the testing. We go in once a month. We collect demographics, risk assessments, and consents to test. We then perform the testing. Next slide, please. After somebody is confirmed HCV, we will notify the person of the results. We will then try to try to narrow down a release date. I then will create a reminder system at my job at the public health department to help link that person to care once they're released from jail. Our county jails do not provide treatment for hepatitis C simply due to cost. So we will track that individual's release date, and then coordinate and link to care for successful hepatitis C treatment after they are released from the county jail system. If an individual is sentenced to the Idaho Department of Corrections, so the prison system, the treatment will be made available to them once they are incarcerated at the prison. Next slide, thank you. Just one success story. This patient also kind of triggered the discussion into what we can do to help provide treatment in the jail. So this one is a pretty cool story just because of what it subsequently triggered for us at the health department. So a 48-year-old man who was a person who injected drugs had a confirmed chronic hepatitis C diagnosis with a genotype of 2. He was denied patient assistance for Epclusa due to his incarceration. I anticipated this would be the case. However, in the paperwork for the patient application, or the patient assistance application, it did not specifically say that incarceration wouldn't be a disqualifier. So I went ahead and submitted the application anyway. It was then subsequently denied. I was able to track his release date. And then after about 2.5 months after his initial diagnosis, he was released. I was able to follow up with him. We started Epclusa through the patient assistance program once he was out. And then his SVR-12 did confirm a cure of hepatitis C. So like I said, his case kind of triggered our pilot project that we're working on currently. Next slide. Okay, so some lessons learned that we've gathered is just venipuncture versus point of care. We have seen an increase in testing participants because of point of care testing. And then also what we identified was there's a lack of funding for treatment in the county jail level. And also individuals lose their insurance coverage when they are incarcerated, specifically Medicaid. So those are some of the things that we wanted to look at and the lessons learned from testing in the county jail system. Okay, so we then identified this gap of lack of treatment in the county jail system. So we started a pilot project. So as we talked about, we got the hepatitis C confirmatory testing funding, which was great. But now what? If we confirm it, is there something we can do to try and treat it in the county jails? So as we discussed before, we attempted the patient assistance application. It was denied. So what else can we do? We did reach out to Gilead so that they could give us some information. How, is this a barrier that we could resolve to try to get these people treated? We believe that the county jail system is a perfect place to treat because they're having someone help them with their medications. They're in the jail, so they won't forget to take their medicines, or they may not forget follow-up, things like that. So it would be a good opportunity to see if we can treat people while they're incarcerated. So when we reached out to Gilead, we talked a lot with them, and we kind of finalized on what about a research opportunity. So we then applied for a collaborative study, which was approved in November of 2023. So we are going to be able to enroll 100 eligible patients to receive free study drug, Epclusa, to treat chronic hepatitis C in the county jails. This is not a study of the drug itself. It's a study to see if the county jail system is a feasible environment to treat hepatitis C. We're also going to be able to increase our testing to twice a month. We have finalized our protocol, and actually just as of like a day or two ago, we have full approval from the IRB so that we can start our study. Okay, next slide, please. Oh, and that is it. Hopefully I captured everything. Thank you so much for this opportunity.
Thank you so much, Rachel and Danae. We do have quite a few questions, it looks like. One of them was just another request to connect with some of the speakers, this one specifically for Megan. So maybe you all can just drop your emails in the chat if you're open to receiving some correspondence from folks, and then through these questions. This one's for Megan, but Danae and Rachel, if you're able to speak to this as well, that would be great. Can you talk more about how you use the 340B drug pricing program to support treatment? How does that relationship work between you and or the local health department and the jail?
Yeah, so I can definitely go first. So at the Ohio Department of Health, we actually have an STI medication program where we also purchase all of the drugs. So we don't just confer eligibility to our local health departments, but we also buy them and provide them free of cost to the local health departments. So for most of our folks doing these relationships, it is that they're part of our medication program. Many of them are also receiving funding from us, or we, provide TA. We have free condom projects. They are also getting condoms from us. So we have relationships built in that way. Most of it's local public health. We do have a multi-county juvenile attention center that is a direct member of our STI medication program, and then one county jail that has actually the contracted medical care within the jail is a member of our program. But other than that, we are providing both, we do confer eligibility for 340B, but we're also directly providing the medications. I don't think we have anybody, well, you couldn't. I was gonna say, I don't think we have anybody just using the eligibility to then purchase their own and use that for like rebate purposes, which does happen in other relationships, but that they can't charge folks in jail for the medication via their insurance, so that is not relevant. So yeah, mostly it is for us through our separate medication program. I don't know if there were other parts of that question or if that answers it.
Let me look back. I think you answered it. Yeah. I don't know if Danae or Rachel, if you had anything to add.
We utilize 340B pricing to treat for other infections like chlamydia, gonorrhea, syphilis in our jails as well through our STD subgrant is how we are able to use that 340B pricing. We have not been able to utilize it for our hepatitis C treatment just because of the cost.
Okay. Another question is, what is the confidentiality process for inmates once they test positive? Who gets to know their status? How is that information kept private from other inmates?
I can take that first. I know I kind of previewed that was an issue for us in the pilot project, especially, but then we knew like down the road to kind of foresee that a little more. It helps to keep the person right in front of you through all of the testing so you can deliver the results directly to them. Jail staff did need to know if we needed to come back for treatment or follow-up testing, anything like that. But otherwise, it was just a direct conversation. So, and all of the spaces were completely private from any other inmates or other staff that didn't need to be there. So it was a pretty closed situation. I don't know if that, or if Rachel probably has Rachel's been in the jails. I'm sure she has other.
Yeah, so when we do our testing, we are in the actual medical part of the jail. So it is private, and we only bring individuals back one at a time so that we are able to ensure that confidentiality. We do have to collaborate and to discuss with the medical part of the jail, not necessarily in officers or jailers or sergeants and people like that. But it's often a coordination of care with the other medical staff. And then we also have the opportunity to have the patient sign a release of information if there's anything that needs to be disclosed elsewhere besides through medical staff.
Awesome, thank you. Another person asked, is there ever pushback to information sharing / collaboration between DIS and jail staff?
We see not so much pushback to information sharing with jail staff. We see that a lot more with recovery facilities. I know like people everywhere have that problem. But we generally don't have a problem with jail staff, at least confirming that somebody is there, if it's something like that. So I think no is my answer.
I would say the same. I think for us, our county jails work very collaboratively with their public health partners. And like Rachel's public health, they do the DIS. And so I think Rachel can touch more on that, but they work very collaboratively together.
Yeah, I think that we've been really fortunate with our county jails. They are very supportive of us. They're grateful for the services that we're able to provide at the public health department. And being able to come in and provide treatment and to help provide partner services, they're very supportive of us. So we're fortunate in that way, and we do not have a lot of pushback or we don't meet a lot of resistance with our jail staff.
All right, we have a few more questions. It looks like about 5 more minutes. Someone asked, was there also a coupling of prevention services like PrEP or care services like ART or counseling?
Yeah, so for us, for testing situations where it's like local public health going in, I don't think we have seen that. Counseling for positives is always a yes, and risk reduction counseling is generally what happens kind of while they're waiting for test results. So that part is a yes, but for PrEP or I don't think we've had any HIV positives in our programs we support. So the art is hasn't happened yet. PrEP integration would be great. We haven't seen it. I think that level of integration for public health is just not there. A lot of our public health departments don't provide PrEP, so it's like, who would be doing it? I do think, I know that FQHCs, and when we have FQHCs that are doing the jail testing, so we've been part of those conversations for more integration of FQHCs into prison systems. It wasn't specific to PrEP. I'm trying to think because we have like a lot of different setups, right? So have any of them done that? And I don't think so, but we do have, there's one in Cleveland, or there's one FQHC there that I'm thinking might do that. I think they're pretty integrated with their local jail, but I don't know what all they offer. They operate pretty independently because they are an FQHC. They have other funding and they have other 340B eligibility. And so we just know they do great work, and we give them the thumbs up when we can. And so that's a good question though.
We incorporate PrEP education within our risk reduction, similar to what Megan had said. We do not provide PrEP at this time for people who are incarcerated. As far as ART goes, we would, in the event of a positive HIV that was maybe a new diagnosis, or even somebody who's been incarcerated in a known HIV diagnosis, we would work with our Ryan White B program to help get them the medication so that they could continue treatment while in the county level. And then once they go to prison, then they'll be able to provide that. But on the county level, we would work with our Ryan White B to help with the ART.
All right, we have another question here. Can any speaker talk more about the CLIA compliance for these settings? What type of CLIA certificate is used to allow testing? Does the jail medical director act as the laboratory director, or is the testing an extension of the public health facilities that go in and perform the testing?
So ours is an extension of public health with our CLIA certificate. And if you'll bear with me for like 2 minutes here, I will find my CLIA certificate in here so I can tell you what kind we have. I should know that off the top of my head, so I apologize. Megan, I don't know if you have anything to add to that while I'm pulling this up.
No,
okay.
Stare at you.
So our clinician that writes all of our standing orders is the person on our CLIA certificate. And so it is not the jail medical director, but we do have an MOU with our county jails to allow us to go in. And so really all the services we provide are an extension of public health. We don't necessarily have separate CLIA certificates or things like that for those facilities. We are just coming in as the public health under all of our existing waivers and things like that.
Thank you. Let's try and squeeze in one more question. When public health is going in to do the testing, what do the partnerships look like between them and the jail? Are they partnering with another county agency to do this, or are they partnering with a contracted medical provider who maybe provides STI testing?
For me, the answer is yes to both. We work with both the counties and we work with the contracted medical provider. Again, through the use of MOUs and MOAs, uh, our Board of Health through our public health district is staffed by county commissioners. So we're able to help foster that relationship by saying, we're able to have this funding through our funding sources, and we can help save the county's money by not having as high of medical costs for if we're able to go in and do testing and treatment. So it's a county level savings, but also for the contracted medical provider, because they don't typically provide testing unless there's an absolute need. So as far as screening, they don't really do it in our county jails. And so we're able to bridge that gap with them. And so we are partnered really with the contracted medical provider and the county level.
Thank you so much. And we are actually right at time. Thank you everyone for being here today. Just a reminder, the speaker contact information is in the chat. You can see all their emails there if you want to reach out to them and ask them more questions. You can access this recording at our clinic webinar archive on our NCSD page. I did put that in the chat way back as well. And that should be about it. Thank you so much for joining, and thank you to all of our wonderful speakers for talking about their expertise and their experience. Everyone have a great day.